reason why we need new drugs and products is that the mortality rate in an HIV positive treated patient is still higher than the age-matched population. Part of it has to do with the drug toxicities, but also part of it has to do with simply still being HIV and undetectable. And a lot of that is being triggered by the chronic inflammation that we're learning more about is being a trigger to some of the problems that we're seeing with HIV, cardiovascular issues, metabolic issues, and the like. And you'll see a theme at this conference, more and more of these inflammatory pathways being an important concern in morbidity and mortality in HIV patients. And that leads to the presentation that I made, which is a new compound called Cenicriviroc. Cenicriviroc is a potent anti-HIV agent as a chemokine CCR5 antagonist in nanomolar concentrations. But as importantly, I think, it is also a blocker of CCR2. CCR2 is a chemokine receptor on cells called monocytes, and monocyte activation has been shown to be implicated in a variety of clinical circumstances: liver fibrosis, hepatic steatosis, diabetic nephropathy, metabolic syndrome, and cardiovascular issues. And so the dual mechanism of action of Cenicriviroc may have some activity in not only being an effective HIV agent, but also perhaps have some activity if this pathway is important in the development of these issues, blocking that pathway and decreasing some of these issues. So in our study, it was a dose-finding study of 143 patients looking at 2 doses of Cenicriviroc, 100 milligrams and 200 milligrams, and we compared it to the standard of care, which is efavirenz with Truvada. This particular study was a placebo-controlled study, and because of that, the patients had to take a number of pills in the study. They had to take 4 pills in the morning with breakfast. They had to take a pill at bedtime, which was efavirenz or placebo, and they had to take Truvada. So as compared to modern-day heart, this was a very difficult regimen for patients to adhere to. When you look at the outcomes of the study, what we were able to find is that both of the doses of CVC or Cenicriviroc performed similarly to the standard of care of efavirenz. Importantly, the subjects that are in the CVC arm had less adverse events requiring discontinuation of Cenicriviroc as compared to efavirenz. And then those that did not have virologic success, much of that lack of virologic success was driven by drug bioavailability. In other words, if the patients took their drugs and they had high levels of CVC at a minimum concentration, you saw a trend to better virologic outcomes in those subjects that had enough of CVC on board. Importantly, also with this inflammatory component that I was able to show, at least at 24 weeks, there were markers that we monitored that showed effective blockade of CCR2, suggesting that we were having some activity in the monocyte pathway. And importantly, there's a marker called soluble CD14 that has been shown to be an independent predictor of death in HIV patients in the study called SMART. And this was independent of viral load, independent of CD4 count, and independent of the drugs that the patient was on. And in this particular study with Cenicriviroc, we saw declines in soluble CD14 levels at 24 weeks as compared to a trend of a rise of soluble CD14 markers in the efavirenz arm, suggesting again an early look at the fact that we may be having some effect on some of these inflammatory pathways that may be leading to morbidity and mortality. So based on this particular study, we're going to be moving forward with phase 3 studies with Cenicriviroc that will be given in a more, what I would say, modern heart fashion, as a single tablet regimen in combination with some of the other antiretroviral agents that are available. Importantly, I think the endpoints of this study are not just viral load control, not just CD4 increases, but whether or not we're having action and activity against the inflammatory pathways that we're seeing, whether or not we're having action against the metabolic side effects that we're seeing in patients, and whether or not we can make significant impact in some of these other endpoints that are not simply control of HIV viral load.